Good afternoon and welcome to today's program, titled Behavioral Health in the Digital Age. I'm Gary Enos, editor for the Institute for the Advancement of Behavioral Healthcare. Today's program is sponsored by Foundations Recovery Network. Thank you to our sponsor and to our audience for giving us your time and attention today. Before we get started, we have a few details we'd like to go over. To submit a question for our presenter, please use the Q&A area below the slides at any time. You do not have to wait until the end of the program to ask a question. If you are having technical issues, please click the Test Your Connection button below the video window to chat with support. Finally, to download a copy of the presentation, please click the link in the Resources tab to the right of your slides. I have a special note about CE credit. To get your CE, you must watch the program all the way through the Q&A section at the end of the presentation. At the end, do not leave the web page. The site will automatically redirect you to a survey. This must be completed in order to generate your CE certificate. For those watching in a group, please download the group submission guide in the Resources tab and follow the instructions provided. Please note that CE credit is not available for the archived webinar. It is only available for the live event on September 25th, 2018. Finally, for those of you who tweet, please tweet along with us using the hashtag IABHCLiveWebinar. At this time, it is my pleasure to introduce our speaker, Lisa Henderson. Lisa Henderson is the co-founder and COO of Synchronous Health and president of the Tennessee Counseling Association. She has worked to craft legislation that allows greater access to mental health care for students and specialized trauma care for first responders. She also serves on the board of the New Beginnings Center, a social enterprise addressing women's health in underserved populations. Thank you, Lisa, for taking the time to speak with us today. And with that, the audience is yours.
Thanks, Gary, and thank you, everybody, for attending and being part of this program. I think this is one of the most exciting conversations that's happening in behavioral health right now. There's so much going on in behavioral health just as a whole, whether we're talking about integrating with traditional healthcare, or if we're talking about solving some of the biggest challenges, thinking about the opioid crisis and what may come next from that. But looking at any part of the piece of the conversation, having technology to help scale and access care for people who might not otherwise receive it is just an absolute must. And so we'll get into some details about how and why that is and what technology has to offer us and how people respond to technology. So I will give a little bit of a disclaimer. There is a lot of research to be done yet in this field, and so everything that we're going to discuss today comes with the caveat of kind of figuring out where you're comfortable using these tools and looking at, what do we know in the field? What does the body of research tell us about how and when it's appropriate to bring some of these tools into your workflow? So we have a lot to cover, so we will jump right in. So I wanted to set the stage a little bit. When you look at this picture and you think about, working with a client who, this image represents a client that I work with who lives with depression, and just getting out of bed is such a challenge for her. Getting those 2 feet on the floor is the hardest part of her day. And, everything that we do around in session, trying to help make that an easier, more effective process for her, she has to do it on her own. When she meets with me, we're in my office and we're talking about skills and strategies and, kind of preparing for the how and when. But when it's time to really put those into practice, she's there by herself trying to just will herself into practicing what we've discussed in session. But we know that if we can, get outside, get fresh air, get sunshine, get exercise, that's some of the most important and critical pieces to depression care. So is there a way that we can be with our clients when we're not actually with them, support our patients outside of our four walls, and help them get from, unable to get out of bed to really enjoying, having that outside time and all the other things that create wellness and well-being and overall highly functioning folks. So that's really kind of where this journey started. This is my team, some of the core members. You see me right there, second from left. I worked with Katie Lohr right next to me for about 8 years. We worked in private practice together. We started a treatment center together. And essentially, she and I lamented over, we've got these great programs. People, seem to really enjoy coming. They keep coming back. Our no-show rate is really small. Our ability to help people seems to be great, except for they don't really seem to be getting better. When it comes time for them to say, how this intervention worked outside of, this treatment center, the outcomes just weren't good enough for us. They would either forget to use the interventions or they were too triggered to use them when they needed them. And they just kept saying, if you could have just been there with me, if I could have just had you right there on my shoulder to tell me and remind me what skills to use in this moment, maybe I wouldn't have had that drink, or maybe I wouldn't have yelled at my kids again. And so we started thinking about how can we be with people when we're not with people. And so the two of us got introduced to Guy Barnard, who at the time had just finished his role as Chief Information Officer at a large public company focused on population health. And so they were doing a lot of disease management, diabetes care, and he was frustrated with the fact that they just kept bumping up against behavioral health conditions, and that's just not part of, what they did. That wasn't part of their care plan. So the three of us got together and we came up with this company, Synchronous Health, and you'll see Carla all the way on the right side. She's our bot, and essentially what she does is extends the care that Katie and I can deliver in session to the moment that our clients need it. So after I have a session with somebody, I will tell Carla what they're going to need and under what conditions. And then Carla looks for those conditions and delivers the intervention. So an example might be if I'm working with someone who's in early recovery, living with alcoholism, and we've got their hotspots listed on a heat map. I can say, if they go to any of these places and they're there for more than 3 minutes, send them a message that says, now's a good time to call your sponsor. So they get that in the moment, decision support at the moment they're going to need to make a decision of, do I go in there or do I not? The reason we have things like, wait 3 minutes is because they could just be driving past it. It could be, on their way home. But if they actually pull in the parking lot and, turn the car off, then that's the very moment that they need some support. And so Carla's able to extend the care that we provide in session outside when they're in the real world and in their real lives. So that's just one example of how technology is really extending and expanding the ways that we can support our clients in the exact moment that they need it. So today we're going to go through some things that are existing right now and some things that are coming in the near-term future. There are a few things that we'll talk about that are further out, but I really wanted to focus on what's available to you today. We're going to look at the difference between scaling access to care so that clinicians are able to see more people or more people are able to access clinician services versus actually scaling the capacity that the human clinicians have. So we'll get into the nuts and bolts of that a little bit. And then we're going to describe what the provider's role is in these sort of supported technology-enabled services. We think it's really critically important for the provider to sort of remain at the core of care. So we'll talk a little bit more about how and why that's so critical and how to preserve that within the technology advancements in the field. And then we'll look at how to determine which technologies are appropriate for your work setting. So we'll cover all of those and more, but if you do have questions, please put those in the comment section and we will get to those at the end. So just to talk a little bit about why this is important, and many of you I'm sure are well familiar with this data, but in our lifetime, half of us are going to need care at some point. So, whether it's now or 5 years from now, at some point in your life, you have a 50% chance of needing care. And then about 60% of those who need care never get it. So we're looking at, a very small portion of the population who's getting what they need in order to really live up to their fullest potential. We also know that 45% of people who die by suicide have visited their primary care physician within a month of their death. So we're looking at this going, okay, what is going on? We've got people who are not able to get care. We've got people who are actually reaching out and trying to get care, and that's not helping. And so we look at this and say, well, what it looks like to us is that something's broken in the system, that the traditional model of, the patient is suffering, the patient reaches out for care, and then maybe they go to the right place, maybe they don't. If you're going to a primary care physician and you're feeling suicidal, chances are you may or may not share the fact that you're feeling suicidal. And if you do, you may describe it as depression. And if you describe it as depression, you're most likely to get a prescription. And so there's very little, engagement with a mental health provider under those circumstances. In those cases where somebody is given a prescription, sometimes they take it and sometimes they don't. And we don't have really good population level data to look at, did this person go to the right place for care? Were they given the right level of care? And then did they get better as a result of that? And so one of the things that we're really looking at being able to do is, some of the advances that are coming is just that, to be able to predict for an individual, what are they going to respond well to, and so how do we get them in that kind of care as quickly as possible so that we don't have people either not accessing care or accessing the wrong kind of care. Another big challenge with folks who go to their primary care physician is that they're looking at, a medical condition, and if it's outside of that, a lot of times they'll try to make a referral to a behavioral health provider. And what we're finding is that on average, it can be anywhere between 4 and 6 weeks to get that referral if it gets followed through with. But we're also finding that so many physicians have had such negative experiences with trying to refer into the behavioral health care market that only about 22% of them make the referrals. And that's due to, either my patients won't follow through, my patients aren't able to use their insurance and so they can't afford it, or the clinicians, I don't know any clinicians who work in behavioral health, so I don't even know where to send them. So all of that kind of combines into this really low referral number. That is changing a little bit with some of the integrated care initiatives that are going on across the country. But overall, it's not, no one has cracked that nut yet. So there's lots of room for improvement. Another challenge is that 55% of U.S. counties don't have a single licensed behavioral health provider. And so we're looking, across multiple licenses here, from master's level, but yet independently licensed to practice, diagnose and treat, all the way up to psychiatrists, and everything in between. So when we look at that sort of scope of services, it's no wonder that people are having trouble accessing care, because so many counties are just not served. I live in Nashville, and I've had clients drive for 3 hours away to come and receive care. Now, they could have driven 2 hours instead of 3. There are clinicians within an hour of me, but for some reason, there just aren't any where they live. And so you look at kind of the imbalance there. It's almost a supply chain issue of, you've got a high concentration of counselors and therapists and behavioral health providers in highly dense populations. And then you've got these rural areas which have as much suffering and unable to access care, within a couple hours drive of them. So another aspect of this is that, we couldn't possibly take care of everybody who needed it. When you look at the data and look at how these things, the numbers shake out, you've got 1 in 3 of children with emotional and behavioral disturbances have inadequate insurance. So their families are unable to access care without paying out of pocket. And then 1 in 3 adults with a disability couldn't afford to see a doctor. And we know that, disability and behavioral health are closely correlated. So we're looking at, if you can't afford to see the doctor for your disability, then you're unlikely to be able to see a behavioral health clinician for the co-occurring conditions that you're going to experience there. Nationally, there's only 1 mental health provider for every 790 individuals. So that shakes out to, if we're just looking at the population of those who need care, that's about 1 to 200. So I think about, having worked in private practice and having a caseload of, 35 or so, and then needing to bump that up to 200, that puts a lot of stress on me just even thinking about it. But being able to become more efficient and be able to serve more people, maybe we could make a dent in that ratio. And then 19.6% of the national readmission rate is linked to unavailable community-based services. So people just can't access the care that they need, which is not new. We have certainly known that. And 70% of those who receive mental health services report that they've improved social connectedness. And we know that, people suffer in isolation and they heal in community. And so if we're able to see numbers like this, that there's a 70% improvement in social connectedness, then we know we're on the right track to people really getting better. So all of this kind of goes to show that we can't necessarily just do more of the same thing. We need to, really identify the areas that we can make strides in and increase our ability to serve people whether they're right in front of us or not. So when we look at, how this all adds up, according to dollars and cents, it's a pretty big problem. So behavioral health accounts for about $525 billion in the U.S., and that's a big chunk of the pie when you look at the total healthcare spend. So where this really shows up is that if you look at, and this is a study conducted by Milliman, if you look at somebody with a medical condition and you compare them, you pair match them with someone who has that same medical condition, but also with a behavioral health condition, we see a 2.5 to 4 times multiplier in their total cost of care. So if you look at somebody who has arthritis, and if it's arthritis alone without a mental health condition, it's $814 a year to take care of them. But if they have a behavioral health condition with arthritis, it jumps up to an average of $2,065 a year. And we don't think that that's just because of the cost of medication or counseling for that depression. We think it's also a matter of if you are living with depression, you're less likely to be able to do the things that are going to help improve your arthritis. And so if that's being compliant or adherent with your medication regimen, if that's doing the exercises or the physical therapy or the yoga that is prescribed to help manage those symptoms, if it's connecting with others and giving yourself that community to help manage just the psychological aspects of things. All of those things get negatively impacted when you've got a behavioral health condition, which just totally exacerbates the physical condition that you're living with. So there's a lot of room in the system here. The medical system, employers, the insurance companies, everybody's starting to really recognize the importance of behavioral health. So everything we talked about up until this point is about, the capacity issue. And so people aren't getting the care that they need. If they are getting it, maybe they're going to the right place, but maybe they're not. We don't have enough providers in the system as it is. And numbers like this and the information on this slide really highlight for us how important it is and how much more recognized it is becoming in the healthcare system at large that we address behavioral health conditions. So all of this comes together to create a picture of the need is really ever increasing, and it's going to continue to increase. And it might get to a point where, the floodgates really get opened up, and with the capacity that we have in the system right now, we are not going to be able to support it. So that's where we start thinking about solutions, because all of these challenges are really opportunities for solutions. So when we think about, how that might get started, the first thing that can be done is just using telehealth. So for my client who lives 3 hours away, she doesn't have to drive to see me anymore. She doesn't have to take an entire day off of work and find childcare and pay for the gas and all those sorts of things that go along with that. She can just log on to our secure video. We can have our session. I can message her securely in between sessions. And this particular platform is called Simple Practice. And there are lots of them like this. It is very easy to start using telehealth. And telehealth sessions are reimbursable by insurance. And at this point, most insurance companies are paying the same rate as face-to-face sessions. So if I'm treating somebody and I'm seeing them, for an hour, it's, if I'm just traditionally billing, it's 90837 is the CPT code that I bill with. If it's a telehealth session, it's 90837-95. So it's really easy to have all of the same sort of workflow and processes and be able to see people in a way that is much more convenient for them. And I can also, from personal experience, I can describe that when I'm seeing somebody on telehealth, it's a little bit more, it's a little bit easier to manage the time. So I'm still getting the, the facial and the body language cues. I'm still getting the cues in their tone of voice. And, if they're distracted, I can see that. If they are distracted in person, they may be actually less distracted on telehealth. So being able to kind of get the richness of the client relationship without them having to come to my office has been just a great experience for both of us on that particular front. I have another client that I do telehealth with, and she's a young adult and lives in town, and so do her parents, but we needed to have some family sessions. But her parents are both, one of them is a physician at a very busy clinic, and so getting him out of that clinic is just nearly impossible. And her mother is an administrator with the state, and so getting her out of work is nearly impossible. But both of them can close their office doors, log on to the chat, and all four of us can connect on telehealth and have a family session without them having to, again, get out of the office and leave, pay for parking, and all the things that go along with having a session. We estimate that a 1 hour session is actually 3 hours worth of time and energy for the client because of the switching costs from stop what I was doing, get to the session, have the session, get back to the office, and get back into being productive. So that might not be, the length of time for everybody, but it certainly is, when we talk to clients and patients across the country, they do describe, one of the major challenges is that sometimes it feels like the entire day is dedicated to therapy, and they just don't have that time and flexibility. So telehealth is a great option for that. There are lots of digital therapeutics that are coming on the market. These are really exciting to watch. There are a couple of companies that are doing big things in this space. One of them you may have heard of called therapeutics. These images are actually of another company called BeHealth. The name of the program is ShutEye, but BeHealth is the name of the company. And this one in particular is a 12-week program, and it's essentially what happens is if a client is living with insomnia, they may reach out to their physician, they may reach out to a mental health provider, but they are, they are given an assessment which determines that, they do in fact have insomnia, not just insufficient sleep, because that's a different treatment protocol. And if they do, then they can log on and register for ShutEye, and it walks them through 45-minute sessions once a week, and then weekly homework and a daily sleep diary. And it takes about 4 minutes a day to complete that diary. So if you're curious about the outcomes here, there have been about $10 million of NIH research funds poured into ShutEye in particular. And what they found is basically that it works just as well as face-to-face, and in some cases better. The exciting thing for the research team was that not only does it work in the lab, but it works in the wild. So when you're doing a clinical trial, it's such a sterile environment in terms of, the population and the treatment approach, and it just doesn't really reflect what happens in the real world. So to find something that, we've got the clinical trial data and it's really good, but we also have data of what happens in the real world with, messy patient populations and clients who have lots of things going on, and it works just as well. So we were able to see that, if you're looking at the graph here, the red dot is, basically there's a little bit of improvement without ShutEye, but not much. There's still some living with insomnia there and some suffering with that. The purple dot is face-to-face, and so you can see that with face-to-face counseling, they did get better. And then when you look at the white dot and the thick lines, that is with ShutEye. And so, it's about the same amount better as face-to-face, maybe just a touch more. And then the really exciting thing is that the improvement continues over 12 months. So not only do you get better, but you stay better. And so that's exciting to see. And this is just one example of lots of other programs that are digital in nature, self-guided in nature, kind of move at your own pace a little bit, but still within the guardrails of a program. One of the things that stands out to me is that a lot of these programs like this are rooted in CBT. So, when I think about who would be really good candidates for this type of a program, I really think about, who's going to respond best to CBT. And then also look at what is the condition that I'm trying to treat, and what is the kind of body of evidence that supports this treatment program. So another type of programming or type of capability that's out there is remote monitoring. And so, we get things like Scram bracelets. We know about these. These have been around for a long time, and they keep coming back on the market with new and improved features for whoever is monitoring the person. Now we also have things like a Fitbit or any other kind of smart wearable device. These are incredible for tracking things like your sleep, your physical activity, how much time you've had outside versus inside, whether you're drinking enough water. So these kinds of things are really useful for kind of that lifestyle competency piece that wraps around behavioral health. We've got that sort of symbiotic relationship of, a healthy lifestyle and a healthy well-being or having mental health. You don't often have one without the other, and whether one, leads to the other or not, is a little bit up for debate. But in terms of, if you've got one, you're more likely to have the other. So this helps us focus in on those physical health behaviors. But then we go a little bit further and look at things like smart scales. And you also have other smart devices like smart pill bottles where, you're supposed to, it knows if you've opened it or not. It knows how many pills you've taken out because it calculates the weight of the actual pills. So if you're taking more than medication than you're supposed to, or if you've skipped a day, it knows. The pill bottle sends that information to your physician, or it'll send you a reminder. So kind of looking at the best ways to help with medication adherence, whether it's that you need a coaching session to really address the beliefs about the medication and the condition, or if it's you just need a simple nudge, then can tie into a smartphone and send you a reminder. The thing that I really like about things like scales is that, when we're talking about, in particular, medical conditions, if you wake up one morning and you are 10 pounds heavier than you were the day before, and you have, have hypertension, that could be an indication of retaining water. And that could be an indication of something going wrong with the rest of your health. And so that information goes directly to a nurse who then calls you to check in on you and can give you either, change your medication right there on the phone or give you something else that you need to do and triage and prevent having to go to the emergency room. So when we think about this relative to behavioral health, there are myriad ways that we can integrate some of these technologies into what we do on a daily basis. One of these is we know that exercise is, one of the evidence-based treatments for depression. And I keep coming back to that one because, a client of mine has just seen such an improvement in her life since she was able to start exercising. And, being able to use her smartwatch and her smartphone and able to see how often she's exercising, how much she's exercising, and kind of look at patterns of when she does and when she doesn't, and help her really craft her day around making sure that she takes care of herself in that way. So we also have smart devices like Alexa, Google Home, things like that. And these are great for lots of different things. But one of the things in particular is, a study that was done in the UK where they gave them to the senior population. And not only did they use them for connection and companionship, but they also used them for emergency protocols. So if the senior had fallen or, couldn't get out of bed that morning, or if there was any other thing wrong with them, they could say, Alexa, start SOS. And it would go through a list of people to call, starting with family, extending to friends, and then ending with EMS, so that the senior could get the help that they needed, and all they had to do was talk as though they're talking to a friend or a family member. And so the uptake of this technology is really high because seniors get a little, and this is somewhat stereotypical, but the research does support that seniors get a little bit nervous about opening an app, or which app, and where do I press, and what buttons should I press, and all these sorts of things that just make them want to back away from technology. But if all they have to do is say, hey Alexa, start my SOS, then they're ready and willing and really consistent in using that kind of technology. So this last point on this slide is just a really interesting one. There are things that are in development that just, we continue to learn about all the time. And this is an example or representative of, in Poland, some researchers designed a laser that could detect particles of alcohol in the atmosphere up to 50 meters away, and it could be a moving target. So if you imagine a police car driving down the street and just scanning the cars around them for alcohol particles that might be in the air, and to be able to reduce, the idea there would be to reduce drunk or buzzed driving. So the thing that has prevented mass rollout is that the driver might be perfectly sober. It could be an Uber driver, a cab driver, or a friend, and there still would be alcohol particles in the air because of the passengers being drunk. And so they're still getting too many false hits where the human behavior is actually legal and safe, even though the laser has detected reason to stop somebody. So we will see more of this come out, and we'll see more development of things like this. And I think there's an element of, it's really kind of, overwhelming. It's very big brothery in a lot of ways. And also, we're going to see that people take the time to get it right and find the best ways to help people, as opposed to just, law enforcement approaches. So artificial intelligence is another one that we hear a lot about. It is kind of our view that right now computers do a lot of things really, really well, but the things that they don't do well are non-negotiable. So, they can do transactional things really well. There are lots of studies that show that the artificial intelligence is way more accurate at finding cancer tumors than the clinicians, the oncologists and radiologists themselves. So when we're looking at how to use artificial intelligence, there's a lot of promise there. But because humans are so complex, right now everything really needs to be, in the behavioral health field anyway, it really needs to be human-assisted artificial intelligence. So it works great for the AI to surface up, this individual looks diagnostically similar to, depression or substance use disorder or eating disorder. But the clinician still needs to determine, which one of these is primary, secondary, which one of these is the client most likely to be willing to address. And so this is really a human plus tech application right now in this field. So predictive analytics is, kind of a buzz term that we've heard about in healthcare for quite a long time. It actually came out of the insurance industry, where they were trying to predict who would need what kind of care so that they could manage their risk in terms of providing insurance for them. So it's just a statistical technique, or several statistical techniques that look at things that have happened in the past to make predictions about the future. So here's an example of a study that's just really exciting, that shows, with a very high degree of accuracy, the ability to predict how somebody is going to respond to treatment for cocaine addiction. So getting 82% accuracy is just out of this world in terms of, predicting that at a scalable and replicable level. And I'm excited to see what other things are coming in the predictive analytics space. I was just talking with a company a couple of weeks ago that, they look at what is this condition that the person has, what are all the demographic information about the individual themselves, and so then what are they going to need in order to get better. And so it takes a lot of the guesswork, the trial and error out of, well, let's try CBT, well, let's try DBT, well, let's try mindfulness, let's try this therapist or that therapist. And we're going to be able to answer those questions through a predictive analytics model sooner rather than later. And I think that's going to help a lot of people. When we think about the stigma associated with mental health, a lot of that is because, and I think part of the unaddressed problem of stigma is, at this point, it's still viewed as something that you're going to have for the rest of your life, which people interpret as, I'm never going to get better. So people think of it as a life sentence. But if we can find a balance between, with predictive analytics, being able to say it's going to take 6 months for you to get, to this level, and this level means you're going to be able to work and have healthy relationships and, engage in positive activities, and you're going to have a really good life in 6 months if you dig in and do this work. And this is the work that we know is going to help you. I think we would see a lot more people reaching out and getting the help that they need because they've got hope that it's going to get better. Right now, we sort of just give them a promise, and that's not good enough for a lot of folks. I do want to talk quickly about blockchain. I'm not going to go too deep into it, but essentially, blockchain is a process by which we store data and information. And think of it a little bit like a thumbprint or like your DNA, that, you can't really change your thumbprint. And if you put your thumbprint on something, everybody knows, the authorities know that it's you. And so when you think about data that way, we want to be able to know that it is secure, that it is private. We also are promised that it'll be comprehensive because it's one chain of information that lots of different providers add to. So it's one cohesive medical record that has high integrity. We know that what's on that record is true and accurate. It's managed in real time, and it gives a total picture of the patient's health. So that all sounds awesome. I would love to have that. But we have some challenges, and chief among them are security and privacy. And so you can see that while we're promised security and privacy, we also have lots of questions about what that actually means. And so things like, who owns this record, and who gets access to the record, and how quickly can access be generated? If somebody's going to the ER because they've overdosed, how quickly can that ER that might be in a different state get access to the blockchain record and see, the history on this patient? So lots of promises, but also some challenges that just really have to be figured out first. One of the things to really think about is that 40% of data breaches occur from insiders. So it's someone who was supposed to have the information and mishandled it, which led to a breach. So when we think about, the challenges of security and privacy, we're not really talking as much about being able to protect from outside invaders, I mean, that's certainly something that we need to be thinking about and protecting for, but we also need to not forget that, insiders with the information who may or may not, get sloppy or mishandle is a risk as well. So my overall thought on blockchain and sort of the thought in the industry of people who really live and breathe blockchain is that it's a race to see sort of like the DVD versus Blu-ray kind of thing. Like, it's coming, we're going to have it, it's going to be sort of ubiquitous, but which companies are going to really make it there first, we don't know yet. Here's just another graphic about blockchain. I think this goes a little bit deeper than what we need to, but essentially it shows, the doctor, the insurance company, the hospital, the research institutions, everybody kind of being able to access one health profile. So virtual reality is one that I'm really excited about. I was just talking with a university dean about things that they're doing in their program. And so they're using virtual reality for provider training. I've known of some folks who are talking about doing discharge preparation from residential treatment programs with virtual reality. There's some prolonged exposure protocols for PTSD treatment that is happening in some PTSD specialty clinics around the country. Lots of evidence around the success of that, particularly for veterans. And then I also really like the idea of it being applied to Gestalt. So if you think about the empty chair and being able to really have that person that you're imagining in the empty chair be there in virtual reality, there's just a lot of application there for that. Augmented reality takes it just a little bit further. This is still a fairly new industry, but it's growing so fast with $80 billion in sales predicted by 2025. Pokemon Go was the most successful wellness program that ever occurred, and it was a total accident. Nobody predicted that all the health benefits that would come with getting people out chasing these little Pokemon all over the place would result. And so that just reinvigorated all the excitement around augmented reality. So the way that we think about using it in behavioral health is, if I'm working with somebody specifically around insomnia, or if I'm working with somebody specifically around depression, I'm going to ask them questions about how their bedroom is set up. And if they can, use their phone and use an augmented reality filter on their bedroom, then we can really start to look at, we need more light. We need, if we're talking about depression and being able to get up in the morning, you need more light, you need, a place for an alarm clock, you need, these specific things that are going to help create the environment that's going to allow you to get up faster. If we're talking about insomnia, we might be talking about, okay, those curtains aren't quite going to do it. You need some blackout shades, and look, here's some on sale at Target. Or you need a place to put your electronics so that they're not in your bedroom, get that out of the bedroom. And so you're able to really get a picture not only of the environment, but also make recommendations and pinpoint exactly how and where they can order things. I mean, imagine if we, tapped into Amazon and here are the exact shades that you need, order with one click. Here's, the bedding that you need, order with one click. Here's the mattress that you need. I literally just bought a mattress on Amazon yesterday. So being able to kind of tap into, the wider array of what technology has to offer to just move these things forward. And then when you think about tapping into things that are available today, like Hue, which is the light bulb that you can program from your phone, and be able to program Hue and Alexa to turn the lights on and turn them up gradually so they get to sunshine level, and then start Alexa playing music that's going to help you wake up, and let the volume come up gradually so that you've got this kind of a wake-up experience as opposed to, what I imagine the person waking up in this room has currently. So there are a lot of ethics to consider. We won't go into those in this exact presentation, but essentially, it's on each of us to know exactly what we're comfortable with. And if we're not comfortable with a particular technology, then we need not introduce it to our client. And being part of the healthcare team also means being part of the business side of healthcare. And so really kind of looking at what is the scope of your responsibility in terms of, is this technology going to, be better for the business? Is it going to be better for my client? And where do those two things intersect, are really key for us as clinicians. One last point about ethics. I think we're going to need to really make sure that we've got clinicians at the table developing these technologies, because it would be very easy for them to go in a direction that is not useful. So, for example, there's some talk of being able to detect people who are on the verge of becoming manic and targeting ads at them for things like theme parks, Las Vegas, etc. If we are not part of that conversation, then that's an exploitive practice as opposed to reaching out to them and offering support and help. So with that, I appreciate all of your time and attention, and I will turn it back over.
Thank you, Lisa, very much for a very informative presentation. Folks, before we get into the Q&A portion this afternoon, I want to hand things over briefly to Christy Chrisman from Foundations for a few words from our sponsor. Christy?
Thanks, Gary. Heroes in Recovery is a grassroots movement to break the stigma of mental health and addiction, powered by Foundations Recovery Network. The Heroes in Recovery 6K virtual race series encourages participants to run to celebrate their own recovery, walk to remember a loved one they lost to addiction, or just be part of the movement. Our races aren't just about crossing the finish line. They're about bringing together a community to support local charities and break the stigma surrounding addiction and mental health issues. No matter where your finish line is, your virtual participation at home makes a tangible difference all over the country. To learn more and to register, visit heroes6k.com. Thanks, and back to you, Gary.
Christy, thank you very much. Folks, we've already had some questions come in, and we're going to try to get through as many as we can in the remaining minutes of our presentation today. However, if you still have a question and haven't submitted that yet, you can use the Q&A area below the slides to submit a question. Also, as a reminder, to download a copy of the slides, click the Resources tab to the right of the presentation window. Lisa, we have had a few really good questions come in, and I wanted to start with a pretty specific one about the 9083795 billing code. The person was asking, are these all 55-minute sessions for that code?
Sure, I can answer that. So you're going to actually have different CPT codes for different lengths of time. So 90834 is for 30 minutes, and then there's 45 and 60. So what I've seen and experienced recently is that 60-minute sessions a lot of times now require MD review. And so, being able to leverage technologies that can allow you to work a little bit more efficiently help your bottom line as much as they help your patient flow and your workflow.
Great. Then we had a question regarding billing, and the person asks, how do you handle the billing process? Many states have restrictions that make it seem as though you can do telepsychiatry, but actually if you read the many shades between the lines, there are so many barriers that you really can't do it very easily, such as you have to see someone face-to-face at least annually, or the client has to be in a designated medical facility such as a hospital, et cetera, et cetera. CMS guidelines are very stringent in this regard. Do you see Medicaid, Medicare patients remotely?
So I can definitely relate to the challenge of billing and all of the gray areas and fine print. I think what I've seen as a trend is that, yes, you can see Medicaid and Medicare patients remotely, but primarily for the counseling pieces. The psychiatry piece, there are just so many unanswered questions at this point. I certainly know a lot of folks who are working on it, but, for example, somebody, there are certain medications that you can't prescribe over telepsychiatry. And so you can't just accept this. I mean, you can, but it's hard to work with just, any client who logs on to see you because you don't know in advance whether or not you're going to be able to prescribe what they need or not. So we are working with a clinic in particular where they do the intake for some of their clients, their patients, and they do the psychiatric component, and we do everything else through telehealth. So that's one workaround, but it definitely is an area that needs more attention.
Excellent. Another question from our audience. What protocols are currently in place regarding professional licensing with technology-assisted therapy? For example, providing services to clients over state lines via video chat, etc. Do you license in the state you are in or that which the client is in? What happens when the two states' licensing requirements differ? Any thoughts on that?
Absolutely. This is an area of passion for me. Because I think we, rooted in good reason, we make this very difficult for people, clinicians and clients. Essentially how this works is you do have to be licensed in the state where the client lives. And you do have to be able to provide that care for them. There are some folks who say you have to be in the same state, physically in the same state. Others say you just have to be licensed in that state. And, that's sort of the medical field has kind of been in this space a little bit longer than we have. And they operate at scale where the clinician must be licensed in the state which the patient lives. In the mental health field, sometimes we add on, and you have to both reside in the same state. I think that case law would support the former, but that would be really up to the program that you're working in to make those decisions. I would say err on the side of caution because you certainly don't want to get into a licensing mess. But I know lots of procedures around, in your first session, they have to, when they're on video, they have to hold up their driver's license and, right next to their face so that you can determine that it is actually who they say they are and that they do reside in the state in which you're providing services and are licensed.
Very good, important area. It's clear from our questions that many of the different aspects of your talk really resonated with the audience, and they have questions on several of them. We probably only have time for one more today, so I'm going to go to virtual reality here. Question was, are there any links or websites recommended for the use of virtual reality, in particular for discharge preparation for substance use disorders? Lisa, any resources that you would recommend for people maybe to learn more about virtual reality therapeutic options?
At this point, those are not exactly commercially available. So what you can do is, get a set of virtual reality glasses, the goggles, and kind of look at what games are available that you can create a therapeutic experience from. So again, this is definitely human-assisted tech where the clinician is really curating the therapeutic experience of the technology. They're in development. A lot of them are coming from, essentially how this typically works is that a large organization will commission this work to be done, and then it'll be proprietary for them. In terms of putting it out on the general market, the general commercial market, we're not quite there yet, but we will be.
Very good. I believe that's all the time we have for questions today, so I'm going to pass along to everyone now some final instructions regarding CE credit. Please do not leave this page. Continue to stay on the platform. The site will automatically redirect you to a survey. This must be completed in order to generate your CE certificate. For those watching in a group, as a reminder, please download the group submission guide in the Resources tab to the right of the slides and follow the instructions provided. Please note again that CE credit is not available for the archived webinar. It is only available for the live event today, September 25th. If you enjoyed today's program, please join us on October 30th at 1 p.m. for a presentation with Doug Paul on a multifaceted approach to cravings management. A link to register can be found in the Resources tab to the right of the video window. I want to thank Lisa Henderson once again for an excellent presentation. I also would like to thank our sponsors, Foundations Recovery Network, for making today's program possible. Finally, thank you to you and our audience for participating today. We hope you will join us in the future for another IABHC webinar. This concludes today's presentation.